Transitions of care are necessary yet vulnerable times for patient safety. Breakdowns in communication have been linked to patient harm. Handovers in the perioperative period are threatened by concurrent patient care responsibilities, production pressure, interruptions, and incomplete or inaccurate data transfer. A recent change in the electronic medical record system at our institution has significantly altered post-operative workflow. The change introduced new challenges to handover quality. The prior paper-based tool was eliminated, but the new electronic tool has not been widely adopted by clinicians. The change in workflow illustrated two gaps. First, a mismatch in expectations between PACU nursing staff and anesthesia clinicians. And second, it highlighted that clinicians were not receiving formal training in handover etiquette or science, resulting in wide variations in handover style, content, and completeness. Because standardization of handovers with a protocolized checklist has been demonstrated to improve accuracy and completeness of information transfer, we developed an iPass-compatible cognitive aid with the input of perioperative nursing and anesthesia clinician. The cognitive aid has undergone numerous iterations as we have elicited feedback and worked to improve the utility of the tool.
So we developed a workshop in collaboration with PACU nursing staff to help address the tacit expectations involved in handovers. The goals of this workshop were to incorporate best communication practices in perioperative care transitions and to foster culture change. The brief 45-minute interactive session focuses on teaching theory and practice of optimal perioperative handovers. The session includes a video that presents the viewpoints of anesthesia residents, leadership, PACU staff, examples of poor and high quality verbal handovers, and an overview of the literature and science. The course is co-taught by PACU nursing, anesthesia clinicians, and members of the anesthesia department quality and safety team. All anesthesia residents now receive this standardized training as part of orientation. New residents were also surveyed on their knowledge of the key components of a perioperative handover, their ability to identify specific tools or cognitive aids to use, and their self-assessed comfort level in performing a perioperative handover, both before and after undergoing the formal handover training module.
After rollout of the cognitive aid, handover completeness increased while clinician-to-clinician variability in the number of key handover elements decreased. New residents undergoing the formal handover training module reported an increase in their ability to identify appropriate cognitive aids, as well as increased levels of comfort in performing a perioperative handover. Creation of a formal resident curriculum around handovers also resulted in increased resident awareness of cognitive checklists, which are evidence-based to improve handover completeness and accuracy. We have approached this project with a framework of continuous quality of improvement and are applying the feedback for iterative improvement with each wave of new residents. Data collection is ongoing, but we are using resident feedback to interactively improve upon the cognitive aid and the education module.